So one of the MPNs that we have not discussed is myelofibrosis. So Vikas, what are the hallmark symptoms of patients with myelofibrosis?
Myelofibrosis patient can present with a variety of symptoms. So just for simplicity's sake, we can categorize myelofibrosis symptom into three major categories. Symptoms related to spleen, which are usually abdominal discomfort, early satiety, be feeling fullness after eating small meals, dragging sensation in the abdomen. So those are the symptoms associated with large spleen. The second set of symptoms is what we call constitutional symptoms such as fever, night sweat, weight loss. And these symptoms usually arise because patients with myelofibrosis have high cytokine levels in the blood. And third set of symptoms which we can categorize is cytopenias or symptoms related to anemia. So in myelofibrosis patient, due to the scar tissue in the bone marrow get exhausted in the later stages of the disease, and patient can have anemia. So in a given patient can have sort of, all three set of symptoms, individual symptoms. So patient can present in a variety of ways, but these are some of the common symptoms. There are several risk stratification methods described in patients with myelofibrosis. What are the risk scores you commonly use in your clinic?
So the risk scores also have evolved a lot over time. So we started with the IPSS. Well, there were several other risk scores before that, but the ones we commonly used in practice were the IPSS, which is made to predict prognosis at the diagnosis of the illness, and then the DIPSS, which is dynamic, which means you can use it as the illness progresses with time, DIPSS plus. And then more recently, we have the MIPSS, and then there's a second version of that. So what is most common to these risk scores in general is age, having anemia and the severity of the anemia, and having a high white blood cell count. And then the later scores also integrated platelet count, so having a lower platelet count, cytogenetics, and then the MIPSS and the most advanced scores also include mutations, which are high molecular risk mutations that we diagnose using next generation sequencing. And these scores have evolved over time and allow us really to refine the prognosis of our patients that we see in clinic.
Yeah, I mean, similar to your practice, we mainly use sort of, DIP score, or if we have molecular data available, then we use molecular integrated score. In my practice, I usually use these scores mainly to see whether somebody is appropriate candidate for bone marrow transplantation or not. And then I use symptom assessment to see whether they are candidate for therapies such as JAK inhibitor therapy. So my next question is that there is a lot of, increasing option for JAK inhibitor therapy. And we got a good news yesterday that a third JAK inhibitor, momelotinib, got approved by Health Canada. So we have 3 approved JAK inhibitor for patients with myelofibrosis: ruxolitinib, fedratinib, and momelotinib. How, let's say, access is not an issue, how do you use these JAK inhibitor in your clinical practice?
So, yeah, I think we've come a long way. I mean, for a long time, we had nothing, and then we had 1 JAK inhibitor, and then 2, and now 3. So maybe compared to other hematologic malignancies, we're still behind in the number of therapies, but it's progressing, and I'm very happy that we have options. I think when a patient comes to clinic, our first choice for patients remains ruxolitinib. For the majority of patients, we have the longest term data. It works very well in controlling spleen and symptoms. However, the nuances are for patients who are anemic. Ruxolitinib, despite how well it works for spleen and symptoms, tends to exacerbate the anemia. And some of our patients may become transfusion dependent when they were previously on the border and not really needing transfusion. In this case, the best option would be our newest JAK inhibitor, which is momelotinib, that in addition to controlling spleen and symptoms, also has a positive effect on hemoglobin and may lead some patients who were transfusion independent who were transfusion dependent to become transfusion independent. And for our patients who are anemic and not requiring transfusions, might also improve their hemoglobin or at least prevent them from becoming transfusion dependent as time goes by.
Yeah, I mean, again, at present, wider access to momelotinib is not available. So our ruxolitinib continues to remain sort of drug of choice for first-line therapy. And we're hoping that as the access to momelotinib becomes widely available, there will be some patients who can be either treated upfront with momelotinib, or if patient develop anemia on ruxolitinib therapy, can be considered for momelotinib therapy. And then I usually use fedratinib as a second-line treatment for patients who are intolerant to ruxolitinib or who lose spleen response or have suboptimal spleen response.
So, Vikas, it's become very much a la mode to use immunotherapies in many types of cancers. What are the place of immunotherapies in the treatment of MPN?
Yeah, the last 2 years have been very exciting time for emerging immunotherapies in patients with myelofibrosis, and particularly patients who have calreticulin mutation. There are several immunotherapy options have become available in Canada, and there are ongoing as a part of ongoing clinical trials. What makes CALR mutation a important target for immunotherapy option is the properties of the CALR protein. The mutated CALR protein localizes to the cell surface of the cancer cells, and it then interact with a receptor called MPL receptor and leads to uncontrolled cell proliferation. Now, it is important to understand that it's only the mutated cells, unique presentation, a unique localization of mutated calreticulin on the cancer cells make it a very attractive target for immunotherapy approaches. And at present, there are two types of antibodies being tested in clinical trial. The first is a straight antibody, which is being tested as a part of clinical trial, which attaches to the cancer cells and then leads to destruction of the cancer cell. The second type of antibody is called a bispecific antibody. In simple terms, you can think of bispecific antibody is that the antibody has two arms, and one arm attaches to CALR mutated cancer cells, and the second arm attaches to T cells. T cells are our own immune cells, and this antibody engages with T cells and cancer cells and bring T cells to near to the cancer cells, and these T cells then release some cytotoxic protein and resulting in destruction of the cancer cells. Now, again, this is not available in routine practice, and this is being tried as a part of clinical trial. Now, this type of bispecific antibody approach has been increasingly becoming popular in various other type of blood cancer, such as acute lymphoblastic leukemia, lymphoma, multiple myeloma. And we hope that, in the future, we will have a bispecific antibody or other antibody approaches for CALR mutated MPN as an option.
That's great. And how about CAR T?
CAR T, again, CAR T has been a revolutionary therapy in some of the blood cancers, such as lymphoma, myeloma, and acute lymphoblastic leukemia. There have been some challenges in developing CAR T for a myeloproliferative neoplasm. And it is important to understand that for CAR T to work, we need to have a target which is uniquely expressed on the cancer cells and not on the normal cells, because otherwise this type of approach can lead on to significant bone marrow aplasia. The other problem in myelofibrosis is because of there is a lot of scar tissue in the bone marrow, so that kind of like CAR T cells have limited capacity to infiltrate the bone marrow. However, having said so, there has been a significant progress in this area, and and as I mentioned, that CALR is a unique target, which is a mutant CALR is expressed on the cancer cells. So there have been preclinical models where have been developed for CAR-T in patients who have CALR mutated MPN. In addition, there are other targets such as CD123 and CAR-T being developed for those kind of antigen for patients who do not have CALR mutation. Again, most of the data is in the preclinical area. We are hoping that some of these will translate into human clinical trial in the near future, and that will help us in understanding the role of CAR-T in myelofibrosis or MPN patients. Are there any other? There has been sort of significant number of trials done for combination therapy. Are there any combination therapy partner sort of in combination with ruxolitinib or JAK inhibitor therapy you are excited about?
Yeah, as you said, there have been many trials. Some of them phase 3. So one was pelabresib, and was one with navitoclax. I think that both of these had interesting results. They doubled the spleen response in combination with Rux. However, the symptom response was not as dramatic. I think that there may be a role for these in some patients, but we still have a way to go in order to identify which patient would benefit from a combination rather than have a single agent Rux.
Yeah, I think data on reduction in the spleen volume, which is almost double compared to monotherapy, is interesting. At present, I think we need to follow these patients in the clinical trial on long-term basis, whether a better spleen response will result in better survival or not. So I think that will be a key piece of data we will look forward to. At present, transplant is the only curative treatment options for patients with myelofibrosis. We talked about several new therapies have become available, such as option of 3 JAK inhibitors in Canada, ruxolitinib, fedratinib, and momelotinib. Unfortunately, none of these therapies are curative treatment option, and these therapies are mainly to control the symptoms of the disease. One of the limitation of these medication is that they control symptoms of the disease for a certain duration, and on an average that duration is about 2 years, but some patients have shorter response, some patient can have longer response. Patient who usually have sort of high risk mutations or patient who have higher risk disease usually will have shorter response to JAK inhibitor therapy. The outcome of patient who either do not respond satisfactorily to these JAK inhibitors, or the patient start losing response to these JAK inhibitor, is poor. Our approach is that any patient who is in the transplant age group and has a higher risk disease, to discuss the option of transplant upfront with the patient and provide patient a balanced opinion about transplant versus other non-transplant options that patient may have. In my personal experience, almost half of the patient who are candidate for transplant and have donor choose to go for transplant, and half of the patient, they want to continue with a relatively simpler form of therapy, JAK inhibitor therapy, and some of these patients choose transplant once these therapies are no longer working. At present, we don't have high quality data to say one approach is better than the other. And we are Canada-wide doing a study called AlloBat study to answer some of these questions. So the decision about transplant is a very personal decision. So we always advise patient to make this as an informed decision after gathering the information about both transplant as well as non-transplant option that may be applicable in their individual circumstances. And there is an upcoming American Society of Hematology meeting. Are you excited about any new data or aware of any new data being presented at ASH?
There's always interesting data being presented at ASH. I think we're getting updates on these trials, at least the pelabresib combination. at ASH. I'm looking forward to just learning what other new therapies are on the horizon.